Thank you very much indeed. Tracheal tubes in 13 minutes shouldn't be a problem, really, should it? Right, here we go. Tracheal tubes, ladies and gentlemen. I'm grateful to my colleague Mansukh Popat, who is co-author of the chapter on tracheal tubes, and what I'm saying reflects his views as well, and those of NAP4. You will remember that tracheal tubes were used, according to the snapshot survey, in 38% of anaesthetics during the period of the survey, but they account for some 52% of the cases reported to NAP4. 96 cases overall, and I just want to say right from the outset, we had the largest chapter to write, didn't we, Mansukh? Yes. The outcome of these cases can be seen there. The commonest outcomes being what Tim Cook refers to as front of neck action or admission to ICU, with some death and cerebral damage, much more serious complications. Of the 96, 26 were occurred in the A&E and ICU departments, and they will be dealt with by the respective speakers in those areas. And the other 70 cases were in theatre. And interestingly, when you look at the outcome of the theatre cases, you can see there's a significant difference. I think it's significant, I haven't actually done the statistical tests, in the mortality rate between the two. And that, of course, is a matter which has already been discussed and will doubtless continue to be so during the rest of this meeting. Of the theatre cases, and they're the ones we're going to be talking about during this brief session, a consultant was involved in a majority of the cases, but there were quite a few where no consultant was involved at all. And they can be classified broadly into these categories here. And if we look at those, you can see that the main problem is, perhaps unsurprisingly, failure to intubate, leading to one of the four major outcomes. There are a significant number of extubation problems, but they will be dealt with, I think, by Audrey Quinn. Esophageal intubation that goes unrecognized, aspiration, which is going to be dealt with by Tim Cook, and some trauma to the airway as well. And as I say, I'm going to just look at those ones which aren't being covered elsewhere, so failure, esophageal intubation, and a little bit briefly on trauma at the end. So failed intubation, I think the first thing to say is that although our colleagues who deal with the morbidly obese patients on a regular basis tell us that they're not actually any more difficult to intubate than anybody else, I think that's because they're very skilled. And those of us who deal with them occasionally do find them sometimes difficult to intubate. And you can see that only half of the patients who had a failed intubation were of normal BMI, and the rest ranged from a BMI greater than 25 right up to a BMI greater than 40. So obesity did seem to be a correlation with failed intubation leading to one of the four major outcomes that leads to a NAP4 report. It's good to know that 2/3 of the failed intubations were anticipated and only 1/3 were not anticipated. And they quite different cases in many ways. So I'm going to look at the two types of cases so you get a feel for them. The 31 failed intubation cases where failure was anticipated tended to fall into a number of categories, particularly undergoing surgery for upper airway tumours or for stridor, or with known tracheal strictures. Some of them had been previous difficult intubations, so that's a very good reason for failure to anticipating failure. And more than one was certainly a return to theatre within 48 hours after a previous difficult intubation, and we know that returning to theatre for a second procedure often means that we're looking at an airway that's not only difficult but has airway edema as well. And generally these cases were rescued with surgical tracheostomy or a percutaneous cricothyroid. Two of the anticipated failures, 3 anticipated failures died, but these were patients with known pretty well terminal ENT tumours, and perhaps not a huge surprise of the outcome in these cases. The unanticipated failures are rather different. A lot of them there was no recorded preoperative assessment, or no assessment was carried out. But where assessments were carried out, they were falsely negative, i.e. they predicted an easy intubation when in fact turned out to be difficult. And we know that preoperative assessment tests are far from ideal. 3 obstetric and 1 paediatric cases will be dealt with in their respected sections. And the outcome for the theatre cases of anticipated failure were 5 ended up with a cricothyroid punctural tracheostomy, 7 with non-surgical airways, so that's either rescued with a supraglottic airway or with a tracheal intubation by somebody else. But of course all of these cases, to be included within NAP4, had to be admitted to ITU in this case. So they weren't just straightforward re-intubations by a more senior anaesthetist. There was no death or cerebral damage in any of the theatre-related cases. And a very strong correlation with obesity, with 11 out of the 12 unanticipated failures being in obese patients, and also this includes the 2 patients with the BMI over 40. To give you a typical case, this is case 3 in the chapter, which is why it's so numbered, a failed regional anaesthesia. So this is a patient with high BMI, diabetes, for minor day case hand surgery. Locum staff grade is running the list, does a preoperative assessment which doesn't throw up any particular problems, and tries to do a brachial plexus block, but which fails to produce sufficient analgesia for the operation. He then induces general anaesthesia by an unstated method, makes 3 attempts to intubate, which fail, and also fails to achieve an airway with a laryngeal mask. We get fall into a peri-arrest scenario. 2 consultants come from adjacent theatres, and one of them successfully intubates the patient with a Macintosh, a laryngoscope and a bougie. The patient spent 20 minutes with a saturation that was low, and the lowest saturation was 44%, but after a stay in ITU made a full recovery. The recommendations for difficult intubations are these. We know airway assessment sometimes goes wrong, as we found out, but it's still a good way of focusing your mind on potential rescue methods, plan Bs and plan Cs. And so an airway assessment, we recommend, should always be carried out before anaesthetising a patient. We need to have, of course, plans of failed intubation, and these plans should incorporate different devices, whether you're for using direct laryngoscopy and the device you use for airway rescue. They should incorporate a different device to the one that you're going to have to fail with before you move on to plan B. Repeated attempts with the same device seem, to a certain extent, doomed to failure. Trusts should have explicit policies for the management of difficult or failed intubation, probably based on the DAS guidelines. And these policies should include rescue techniques involving direct tracheal access, which need to be taught and practiced on a regular basis, usually in a simulation environment within the trust concerned. And finally, as we've said, a high index of suspicion for overweight and obese patients, even when such patients have what appears to be a normal airway assessment preoperatively. Unrecognized esophageal intubation. Very different outcomes in theatre as compared to out of theatre, and none of the patients where this happened to in theatre died. In fact, there were only 3, and 2 out of 3 were mistaken for anaphylaxis. And the problem here is that it's often accompanied by a low output state, in these cases anyway, which impedes the capnograph trace, or is expected to impede the capnograph trace. So a lack of capnography trace doesn't alert you the way it would do with a patient with a normal cardiac output. And if you leave a tube down the esophagus long enough, esophageal intubation may present as cardiovascular collapse, which can be mistaken for other problems. Clinical signs of tracheal intubation, as we know, are unreliable. We seem to be finding that other tools, especially fibre optic intubation, may be useful for telling when a tube is in the wrong place. Typical case of unrecognized esophageal intubation. History of asthma and latex sensitivity, so the allergy thing's right up there from the start. A preoperative assessment not recorded. No pre-oxygenation. Bag mask valve ventilation impossible after induction of anaesthesia, leading to hypoxia and a cardiac arrest. Intubation was difficult, grade 3. And there's a flat trace on the capnograph. No action was taken to exclude esophageal intubation because it was felt that the flat trace was due to the cardiovascular collapse, and therefore the tube they thought was in the right place. But when cardiac output was eventually restored, the trace remained flat and the patient was re-intubated. And he is the worst, or she, because I don't know which it is the worst of the cases with a persistent vegetative state out of the theatre cases. You'll see this photograph in the report a few times, or variations thereof. It's what a CO2 trace looks like when effective CPR is being carried out on a patient who has no cardiac output. And it's not usual CO2 trace, but there is a distinct production of CO2 with every breath. The recommendations, therefore, in relation to unrecognized esophageal intubation are, and it will come as no surprise to anybody, capnography should be used during all intubations, irrespective of location. A message, interestingly enough, already carried by BBC Health after a press release this morning. Well done, everybody. Training in capnography interpretation is important, in particular abnormal but not flat traces during low cardiac output states and CPR, especially, of course, for our colleagues in the A&E department. Airway trauma, very briefly. I think I've got a moment. Yes. Let me just go back one, actually. Yeah, there we are. Okay. Airway trauma. Only a few cases of full-blown primary airway trauma, but several where repeated attempts at intubation led to tracheal obstruction due to edema. And that's a typical sequence, multiple intubation attempts causing swelling and edema leading to ICU admission. It particularly happens when tube exchanges are carried out, and there's at least one case where an airway exchange catheter that was inserted down a tracheostomy tube in ITU led to severe barotrauma after a single inflation with a high pressure source. Bougies crop up during this report, causing tracheal tears with pneumothorax and pneumomediastinum, and in one case in the patient with low platelets in the intensive care unit, a massive hemorrhage. It's worth remembering, isn't it, that bougies aren't all the same, and the chaps in Cardiff pointed out that the single-use bougie, as seen there on the right-hand side, is very different to the multiple-use bougie, and you can see the tip looks like it might be more prone to causing trauma than the nice rounded tip of the old reusable gum elastic bougie. And they went on to compare the peak force that could be applied to a bougie, depending upon the distance held from the tip, for both multiple-use and single-use bougies. And you can see that with a single-use bougie, the peak forces in newtons were really quite high, going right up to 10 newtons, which is an awful lot of force when the bougie is held 10 centimetres from the tip. Our recommendations with respect to airway trauma then are that techniques that reduce the need for blind placement of a bougie or introducer probably lessen the risk of trauma, and being able to visualise the tracheal inlet, or at least the passage of the bougie, with a fibre optic scope or a video laryngoscope may be a useful thing. We have no evidence to support that yet. It seems a logical conclusion, but there's more work needed on that. If you're using airway exchange catheters, we should follow the manufacturer's instructions, which limit the depth of insertion to less than 26 centimetres, and a high pressure ventilation source should really only ever be attached to them for necessity only, that is in life-saving events. Thank you very much indeed, and if you want a copy of this presentation, because the slides are actually, because they move around a lot, don't come out very well on a handout, please email me at that address. Thank you very much.